All right, welcome, welcome everyone. Today is a special Friday edition of Airway Circles Thursday Night Live. And today we are joined by Dr. Justin and Kate Roche, and they are joining us all the way from Ireland. Is that right, guys?
That's right.
That's
yeah.
right. Yeah, indeed.
All the way from Ireland, which is wonderful. And so I'm going to take a moment and introduce both of them today, and then we are going to be talking a wonderful topic today. So Dr. Justin Roche is a consultant pediatrician and IBCLC with over 20 years of experience in tongue-tie treatment. As medical director of the National Tongue-Tie Centre in Ireland, he specializes in functional frenuloplasty for infants and children. With extensive postgraduate training, he has refined CO2 laser techniques for selective fascial release and lectures internationally on tongue-tie care. And then we have Kate Roche with us also, who is the clinical director of the National Tongue-Tie Center. And she leads a team of therapists, lactation consultants. And she is a chartered physiotherapist, IBCLC in pediatric rehabilitation. She has trained internationally in feeding therapy, Orofacial Myofunctional Therapy, and Craniosacral Therapy, and now lectures globally on oral dysfunction and rehabilitation. Wow, you guys, that's a lot. We are so happy to have you both here. And today they are going to be talking about doing it our way, how they optimize care in babies, children, and adults. So I do ask, they are going to share their screen today. So if you do have any questions for them, we'll save them for the end and you can just put it in our Q&A box. Okay, guys, if you guys want to, you can go ahead and take the stage and share your screen, and I'll be here if you need me.
Thank you very much.
Smashing. Thank you. Cool. No worries. Right. You're good there. In here, and we should be good to roll. All right.
Perfect. So I suppose we've started here with a picture of our family. This is our 6 children, our eldest partner and our grandchild, and they have very much been our learning experiences or subjects, if you like.
Guinea pigs might be more appropriate.
5 out of the 6 of them had issues with tongue tie, as did our grandchild, and it's really what we've learned through the years that's really got us to where we have been are today. So this journey started, this was nearly 26 years ago now. That picture on the left, that is our firstborn. We were both working on a neonatal unit, so we were lucky enough to draw on the help of a lactation consultant, diagnosed at day 5, type 2 tongue tie, and that was released by a paediatric surgeon the same day. She went on to breastfeed for a year, and we very much felt that, you know, all was good, and we had the ideal outcome. And then it's only as we've learnt over the years and we've recognized how so many issues are related to tongue tie. And this picture on the right is a picture of what her frenulum looked like as a teenager. And you can see there is still evident restriction. You can see that Eiffel Tower sign. You can see the effects on dentition. And she really struggled with many issues. Migraine was a really big one, and sleep, etc. And so what this really helped us see is that we had
because we doing her tongue tie release made her better, so it turned her from a baby who couldn't feed into a baby who could feed, but she was never optimized. Do you know what I mean? So, you know, we got her so she could do, and comparing her to, say, well, certainly the child who didn't have a tongue tie, this little one spent a lot of time feeding, didn't she?
So we got her better. We sorted our immediate problem. But now, having started treating children and adults, we really now see we didn't optimize her for the long term, and she needed then extra treatment. And then I suppose we carry on learning. So this is actually one of our wound care videos that we use in our clinic. And this was our grandson. He was born 3.5 years ago. He had a again, a type 2 tongue tie. And I suppose we managed to help him with his diamond care. He was breastfed, he had lactation support, but we were very much trying to be, you know, we were new grandparents. I mean, the pressure of having both your parents as lactation consultants, and we were learning our way, and we were trying not to, I suppose, overstep the mark.
Yeah.
And we've still continued to evolve things in the last 3.5 years. So although again things improve for him, when we now look at him as a toddler, if we go on to the next picture. So this is him at 3.5. He is an amazing little boy. But again, if we look up closely here, we can see he still has some ongoing issues in terms of sleep quality. You can see the wetness around the mouth, some issues with mouth breathing, some issues with drooling, that's chapping that you're seeing. And so what we're doing now, he's actually currently in sort of preparatory therapy for a frenuloplasty, because the big thing there was he didn't change how he fed. And now we're very much looking at what we do in terms of suck work and what we're doing away from the breast to bring to breastfeeding. He's still breastfeeding at 3.5. But again, his mum had very good flow. He didn't need to work particularly hard, and he didn't change function enough to optimize that outcome.
Yeah, and I suppose, you know, in many ways we're probably preaching to the choir with this kind of one. You know, I mean, I suppose certainly when I started out doing tongue tie releases and that, it was very much driven by its structure. You fix the structure, everything else will all follow in. And I suppose, you know, the two family examples we've given there obviously very clearly demonstrate the fact that, you know, you cannot separate that structure and function, you know. So yes, the structural problem caused the functional issue, but then when we've removed that structure, we've got to ensure that we get that change in function. And by getting that change in function, that also has a positive impact on the healing and therefore the structure that you're left with post-surgery as well, isn't it? So what do we need to do about this, or where we see it?
I suppose preparation is key. This is rushing into surgery just does not work, you know, and we know this in surgery. As soon as that restrictive tissue is released, you can see who has done the preparatory work and who doesn't, who claims that that height. So how do we go about trying to ensure we get those pathways of care?
So what we might do is just kind of run through, I suppose, how we run our kind of under 12-week pathway, and we'll discuss the others as well as we go on. So, but there's no surgery day of evaluation. So there is a separate evaluation appointment, and during that evaluation appointment, you will see one of our lactation consultants, and they are going to make an assessment of that feeding, whether that's breastfeeding, bottle feeding, or combination. I will then see them and do that structural assessment. And then there's preparatory work. And that preparatory work is both from a feeding perspective, but also from a body work and tongue function.
So they'll see, as well as seeing Justin, they'll see two clinicians, one focusing on feeding, a lactation consultant, and someone else focusing on body work, and really giving parents things they can do at home. So this is mouth work, suck work, things they can do like their tummy time, their positioning, looking at tension, looking at stamina, looking at all those different things.
And then from that evaluation, some children will need feeding support. So that's, like Kate's saying, ongoing work with our lactation consultants. Some of them may need feeding therapy. So that means diverting them to see Kate. And for some of that group, hopefully we see a resolution of those symptoms, and then we're going on to discharge them from care. But obviously a number of them are going to need surgery because they're obviously coming to a tongue tie centre because the concern is that they've got tongue tie. So when we look at their surgery appointment today, so it would be, we do the frenectomy first. So these babies are coming ready for to be fed, but we do their frenectomy first, and then they would have feeding support. So their suck training goes in ahead of them starting their feeding. And then there is also the aftercare and diamond care that's taught as well as part of that. And then some of those children will need ongoing feeding support and therapy. So, but you know, everyone will come back regardless for at least one additional feeding support. They'll have a diamond check, so we're checking on wound healing, and they'll also have a session of the body work as well. And then finally, we're going to get all of them to have a follow-up appointment, usually around the 6-week mark post-operatively.
And then this pathway is adapted according to age. So with the 3 to 6 month olds, as a general rule, the longer you've had the problem, the more established your compensations are, and the more extra layers of issues you may have. So the 3 to 6 month olds will often have more therapy interventions. This is often the age group where we're seeing issues such as feeding aversions. And so the really key thing here is individualizing care as is needed.
Then for the older children, I suppose that's probably very much more again what the group here are used to. So we're looking at doing that feeding therapy, myofunctional therapy ahead of surgery, and ensuring that we have them prepped as well as they can be preoperatively, then doing their surgery, and then ensuring that we maintain those changes and get them to take up that extra mobility that they've got in the post-operative period as well to positively influence healing.
And they're looking, those older children are looking at usually a minimum of about 8 weeks before they would be ready for surgery, and often longer.
Yeah. And then adults, I suppose very similar, except, you know, the older we get, the more baggage we have. So again, that lead-in period can be longer, and we've more unlearning, I think, to do really, isn't it?
Yeah, and then we're looking at things like the obviously the airway scans, and there's that whole extra layer of assessment needed with our adults.
Yeah. And then the last kind of pathway that we would have is our intensive pathway.
And this is really, this started off really for international patients. So these were patients where we had consulted remotely, where possible, started some remote therapy, and then they would come to us for a 2-week period. So we have accommodation available to patients, because we were finding that if they were staying in hotels or Airbnbs, they didn't have the equipment they needed to do the therapy. So they come usually on a Monday, in person. It's the first time we've seen them in person, so all the team are doing extra evaluations, but then we're looking at therapy twice a day, and that tends to be a session of feeding therapy or myofunctional therapy, and the other therapy is focused more on the whole body work. So they would have that Monday, Tuesday, Wednesday, Thursday. We then try and do our surgeries on a Friday, so they have a recovery period over the weekend, and then therapy Monday, Tuesday, Wednesday, Thursday, Friday, before going home to their home country. And the big thing about this is we always want to make sure we have them around that day 5. So we know that that's when that contraction of that healing tissue tends to start kicking in, and we want to make sure that we have got them over that hump before they're no longer around for us to help hands-on. But what we were finding was that this intensive way of treatment was working really well. So we're actually now having more families from within Ireland also availing of this pathway of care, especially where we either have issues with an infant losing weight, and there's concern they could end up hospitalized needing tube feeding, or where we have a significant feeding aversion. That kind of intensive treatment seems to
it really works for that group very well, doesn't it? Yeah, exactly. So
preparation, what are we making sure we've got in place ahead of surgery? So a big thing is, I think we need to achieve that neuromuscular re-education. We've got to achieve change and find a way to make sure we're achieving change and function, so that we're going to be getting those vertical forces through the healing tissue to optimize those outcomes. We need to build muscle tone, because if we don't have muscle tone, they're not going to take up that correct resting posture and be able to keep that movement going. They need to know what the correct resting posture is. So we need to make sure, even if they're just getting into the habit of having the tip of the tongue up, once the mid blade is free, it's then going to be much more likely to go into that position. We need to reduce tension, because tension is going to block free movement of the tongue and also block us achieving things like good alignment and postural stability in order to be able to do those fine motor movements of the mouth. We need to increase stamina, because once those changes are starting, we want them to keep going. We don't want muscle ache to kick in or fatigue, which is going to mean they're going to revert back to those compensatory patterns. And then we need to look at anything that's going to block those changes. So nasal breathing is the big one. We need to make sure they can breathe through their nose before surgery, because otherwise they're not going to allow that tongue to rest correctly. And we have one of our team members does Buteyko breathing with most patients over 3.
Mm-hmm. Yeah.
That seems to be something we're finding. They tend not to be good habitual nasal breathers. And address any habits. So the big habits really are things like the pacifier, thumb sucking, things which are going to, again, impede good habitual movements. We need to make sure we've got a really good strategy in place before proceeding to surgery. So it needs to be functional, and it needs to be habitual. So what this means is we don't want to do an exercise program that somebody is going to do maybe once or twice a day, because we're not going to get carryover and we're not going to get enough movement. If we can teach a baby to feed effectively, they're going to be doing those movements thousands of times a day. If we can get an older child or adult to swallow correctly, again, we're looking at least 1,000 times a day just to manage their saliva. So when we're looking at this, we need to manage that the parents are able to help their baby or child. If they don't get enough repetition, we're not going to get that tonal increase that we need. And again, that stamina. We need them to be in a receptive state in order to do that functional work. So that's making sure that we've got that autonomic nervous system engagement, because again, these children haven't had tongue to palate. So they're not going to necessarily have their nervous systems in the best regulatory states. And like I said before, we're going to need that postural stability and correct alignment. Come down. So this is, our babies. So this is just giving you some examples of the things that we will be looking at doing in teaching parents how they can start working with their babies. A lot of it is making sure that the baby is receptive to it. We don't want to be creating any sort of defensiveness, because once you're defensive, you are closed to learning. And we also want relaxation of the tissues. We're trying to reduce tension, and we're not going to do that if babies are stressed in any way. We can go on. Yeah. The older the baby, potentially the more we need to look at other tools in the toolbox. And what we're trying to do is really teach instinctive movements. You know, we're going to need to break down those components of suck, work out what the baby's struggling with and how we're going to help achieve these movements. When we're looking at suck work, we're looking at what do we need to try and achieve? This is a baby who's in that 3 to 6 month age range, so we've no longer got those newborn feeding reflexes to access. We have issues with tension, we have a few issues with defensiveness, and this baby was struggling at the breast. And so what we're trying to do is help work on those components of movement and sucking technique away from the breast. So I often use the Ninny Soother because this is a really nice way to show parents you've got that window of looking into the mouth, and the parents can really see what's going on. Like, you can see the coated tongue, you can see this baby's not getting that posterior lateral elevation. And once we've worked on sucking, we want to introduce swallowing because this adds that whole new layer of complexity onto it. And there's different ways to do it. So, you know, again, we're looking at what's going to work for a particular baby, what's going to work for a particular family. Positioning is very important. So this is a baby where we were actually then using a neurostimulator because he was really struggling with coordinating those movement patterns. And we can probably jump on a little bit there. This is moving on using an NG tube. So this is a really nice way to add in sucking in a way that's very predictable for a baby, because a baby who's, especially if they're struggling with letdown at the breast, they find that unpredictability tricky. And we can also look at what have we got to do to support the suck that we can then add in at the breast. So here now we're looking at choosing a shape of teat. So again, we can have a look and see what is baby doing, what do we need to do within the mouth, and then we can work out the flow afterwards. And if we go on again, we're then working out what they can be doing at home. So this is working with a bottle. For the breastfeeders, we'll often use a very slow flow teat. The Ultra Premium is a really good one because they're really having to work hard. They don't need much milk because they're going to be feeding at the breast, and mums then not under too much pressure to express. We're then working in a breastfeeding position ahead of bringing them to the breast. So we can go on again. So assisting at the breast, and then working out once we've got them managing effective feeding. We can go on again, and then obviously we're working towards getting them doing an effective feeding pattern directly at the breast. Body work is really about increasing those, Grant, it's working on that core stability.
All right.
That's all right. You probably fast track that one a little bit. So we're working on core stability. What we're doing there as well is working on that mouth posture, helping bring that lower jaw forwards, because when you're in this prone position, they're really on full stretch. So that makes it trickier for them. And then you can see in the next one, we're just doing, we can work on alignment. We can work on increasing that tone. and we can work in lots of different positions. If we go to toddlers, we're just then into feeding therapy. So we're applying all the same principles, but we're looking at how we can make this functional. So we're looking at our sensory input to get the motor output we want. So we're using textures, taste, temperatures. We're trying to make our habits working with correct function. And then we just adapt it according to their age, so that as they have more abilities, we can introduce new concepts. And the real advantage of feeding therapy is, again, it's something they're doing regularly throughout the day. So we would often encourage the kind of 3 meals and 3 snacks of that age group, so that we're getting good carryover. With the older children, we can add in more games, fun activities. Again, looking at things like motor planning, core stability, involving siblings where we can, and trying to get them engaged every step of the way. You know, it's got to be fun, or it's got to be functional. And both is even better. So adults, when we're looking at that functional work, those habits are often more ingrained. So we've really got to look at helping them understand how they change those habits. Swallowing is a really big one. Chewing, resting posture, all those things. This lady actually had a lot of issues with asymmetry, which is why we had that neurostimulator on one side. We're then addressing tension. So looking at doing release work is as important as engaging muscle tone. Yeah, we can move on as well.
This video or next?
No, I think the next one. And again, we've got to look at body work. So we've got to look at where all those movements are coming from. We're looking at that alignment. We've got lots of issues with adults, often with a head forward posture, often neck pain, tension, shoulder girdle, and often issues with that core stability as well. So we've got to address all these things if we want to get the best outcome with those mouth movements.
And we might just go through a little bit of a surgery here. So this is a baby who we actually did their surgery in 2 stages. So this is one time where we did do an initial release on the day of the evaluation because it's so tight. What I'm trying to do is release that membrane, but without actually getting into the mucosal or that posterior component. So this basically allows them to get a bit of movement. So you can see there we're getting a better hold than they were before. And then they go off and do their functional work. So they're off doing their suck training and feeding and that. You can still see that there's tension there. So this usually would be a few days for the young babies. And obviously as we get older, that timeline, the gap between them needs to be longer. So and I'm not a proponent of trying to do the fastest release. I try and do the most precise release that we can. We are trying to go through the mucosa, the thick fascia, and leave that thin elastic fascia that's on the muscle belly intact where we can. And you can see there a much better suction hold at the end. And you can see there, like Kate was describing, taking up that height nicely. So you're keeping that diamond on stretch. So that's where doing that work before, whereas this baby was so restricted in the first place, I think it would have been hard to achieve that in one go.
Yeah, because they wouldn't have managed that functional work. They would have had to been compressing too much.
Then the bit that we do different with anyone who is over 12 weeks of age is that we would do a frenuloplasty rather than a frenectomy. So this is done under sedation. So they have a little bit of midazolam, either intranasally or intravenously. We do numbing as well. So they get a topical gel and then inject local anesthetic, and then we're doing very similar kind of release again, trying to get that fascial release and ensuring that we are not leaving tension behind, but equally we are not looking at cutting into muscle when we're doing that surgery either. Slide that along a little bit, because I spend a long time tweaking fascia. But then you can see the release that we've got there, and again that baby's taking up that height nicely. And then we'll close the mucosal layer then using sutures. So again, we're removing that need to do diamond care on these older babies.
And that's a real game changer for parents, because they can really then focus on function. And what we've found is that although the surgery is more extensive, they actually have less issues with discomfort afterwards, because nobody is going in and touching that surgical site with the potential to keep that inflammatory process going. Yeah, you can just see at the end if you want.
Right, yeah. Yeah. And then you can see there we're getting lovely suction hold. Cool. Now then, for the older children, I don't know who's having more fun here actually, whether that's me or the child. I promise I'm doing it for his benefit really, but I might make this go quiet. But you can see here he's actually more bothered by being held than actually having the cannula in, and getting the cannula in is relatively quick. And then giving sedation. And the advantage of getting, for us, giving it intravenously is you see that effect within 60 or so seconds. And you see here he's much more relaxed, but still breathing for himself. This is a little chap who there's no way you would be able to manage him without using sedation.
He was a pre-verbal ASD child.
And then this is him about half an hour after he's come back from his surgery. So busy tucking into his yogurt and chatting away. And he has no awareness that he's had any procedure done, apart from having had a cannula in. So, and then got a little bit of his surgery there, I think. Oops, yeah. Let's see if we can go here. No. So you can see he had quite a tight tie there at the beginning. Good release there. I might skip to the end there. And then once we've done sutures, we're also using the periacral glue as well, much like the guys from the Breathe Institute. And then by the end, that's what we're looking at, having started with quite a tight type 3 tie. Then adults also present their own problems. This chappie there has a very obvious midline vein that's pretty chunky. Oops. Let's see. Might skip through that with his, but so again for his, we just placed a suture just in order to ligate that vessel before we did his surgery. But you can imagine if you end up cutting through that vein, you can end up with quite impressive bleeding, and sometimes they'll be hidden, so they're not there to be seen. If the mucosa or the fascia is a bit thicker, I'll just bring you towards the end here. So that's just his release there, and you can see we're getting little to no bleeding doing that. But that vessel would have been challenging our laser, and then that's what his site looked like at the end. So anyway, we'll skip on. So you can see here, picture on the left is what we'd expect a frenectomy to look like at the end, and then the picture on the right, that's what we're looking to try and achieve with our frenuloplasties.
So then we're looking at aftercare. So the number one is optimal analgesia. So the one thing that is going to inhibit free movement is pain. So we need to make sure that every patient has adequate analgesia so that they keep moving their tongue. That surgical site care, if for frenectomy patients, we've got that open diamond. And I think the best way in order to get that healing well is to try and get the baby doing it. So that means getting them doing that good functional feeding. So they're putting the vertical forces themselves, so that when the parents are coming and doing those stretches, what they're actually doing is just to check. It's not going to be sore because the baby's been feeding well, taking up that movement, keeping it open. The parents are just checking. Whereas without that, if the tongue is staying closer to the floor of the mouth, the parents are then reopening it. And that's then what causes that kind of micro trauma, keeps that inflammatory process going. It's uncomfortable, the baby gets defensive, and you start on this whole
negative cycle, isn't
yes.
it? Yeah. And getting them to change function, you know, we need that function to change, because the whole reason we're doing the surgery in the first place is because it's impacting their ability to function. But by changing that function, we're also positively impacting healing as well. So, and getting them to change those habits.
So this is just a baby who's seeing us post frenectomy. So what we're looking at is we're getting parents to do their mouth work. So this is really looking at those individual tongue movements. We're getting them to do that release work. We're doing their suck work. So we're really trying to engage those optimal suck patterns. Doing a little bit of suck work using the really slow teat. We're working at getting that tension released so that we can get that alignment and unwind where they've been compensating. And then when we manage all those things and that correct posture, we're going to get those good movements. And there's lots of different ways that parents can do this. We want to give them lots of different ideas, things that they can really scatter throughout their day, so it's little and often. We then want to bring all these benefits to their feeding pattern. And then you can see that that diamond is tall and open, and so that's then going to have the best chance at doing the best healing.
Especially if you can get the baby to hold that sort of posture, they're going to do that for hours at a time. Whereas a lift 6 times a day for 30 seconds, that's 3 minutes in 24 hours. So I think these bits probably can't be underestimated, their importance.
And it's having the muscle tone in order to hold it.
Yeah.
I don't know why we keep getting things up there.
That's people clapping.
Oh.
They think you're amazing.
I didn't know that. So then what we're looking at is with older babies, toddlers, children, and adults. Again, it's all the same work, but we've prepared them for this. This is the work they've been doing as they prepare for surgery day, and we're keeping new ideas. We're keeping those movements as functional as possible, because we need to make sure we're getting things like that 3-dimensional rotation at the back. They're getting that back molar reach. I'm a big fan of peanut butter, because it's great to get tongue to palate, and it's getting them into the idea this is all our normal correct habits, getting the family involved. And the other issue you will find, you'll start working with the baby, you'll be getting the parents to model for them, and then you'll see all their own dysfunctions.
So yeah, you also get through a lot of cucumber, don't you?
I do. Gonna love cucumber.
So yeah, and then it's important to follow them up and looking at kind of how they've progressed in that time as well.
And I think with follow-up, the big thing that's probably changed is you now have the option of using steroid injections.
Yep.
And we're using that in all age groups.
Yes.
Babies, toddlers, and adults. And so far, we're having really promising results with those.
Yeah, no, that can be a real game changer for the ones where we're getting suboptimal healing. And I definitely think there is a subgroup that you can do all the work right, but they're healing. They've got a tendency to make a lot of scar tissue, cause a lot of contraction, and for that group it can work really, really well, rather than repetitive surgeries, which tend to give you the same outcome. So again, it's trying to tease through, is it healing that's the problem, or is it lack of change of function that's the issue if you're seeing a poor outcome from somebody who's previously had surgery?
Yeah, and it can be really helpful as well, where, you know, we've tried to get everything right, but then the child's got sick. That's a common one. You know, if they get a heavy head cold in the week following surgery and they can't nasally breathe,
that's definitely negatively impacted a few of the children that we've seen as well. And being prepared to delay surgery. You know, if someone rocks up and they're completely congested, you know, we'll send them away and bring them back a week or two later. Do you know what I mean? And that's certainly a saved. It's disappointing for the parents at the time, you know, and with all the work that's gone on, you know, build up to that. But I think that's definitely a good kind of alternative.
And then we need to look at those other considerations. So the first one, this is actually a typo, I've just seen there. That should be SPD, sensory processing disorders. And this is huge. We actually did an audit recently. 33% of the over 6-month-olds that we saw, so those children, the parents are reporting concerns or known diagnoses of sensory processing disorders. But actually, this is a group we can make a huge impact to. And this often is actually around regulation and sleep. So parents will often come to us, and speech has been the primary concern. And then when they come back at follow-up, they'll be like, oh yes, that's a bit better, but you know what's changed our lives? They're now sleeping, or they're calmer. You know, we're not having the meltdowns.
Well, we can negotiate with them, isn't it? You know, the no doesn't always create a nuclear reactive response like in that. You know, that there's, like, say, you can negotiate and discuss.
And there's also the toddlers, especially the young ones, where there are some concerns, especially around behavior, and you could see how they would end up really struggling integrating with their peers, but we actually can redirect them, you know, get them good sleep, get them down regulating, get them able to effectively communicate, and actually you can change that path at a really important age.
I mean, hypermobility is definitely something we see. Again, I think this is something that we are seeing overrepresented in the group that we're treating. And I don't think that that's something that's exclusive to us. I think it's, once you start looking for it, you will find it, and I think overrepresented compared to the general population. But I think that also has an impact on healing and how we manage sutures and things like that as well afterwards.
And then complex medical needs, you know, these is another group of patients who we can have a big impact on. We often find that if there's another diagnosis, that everything tends to be heaped on that diagnosis, whether it be cerebral palsy or Down syndrome or whatever it is, but you can have coexisting conditions.
Yes. And similarly, you know, like say, we see that the sensory processing disorders is overrepresented. So there's some children who have a diagnosis of autism, and everyone says, oh, they're fussy about the foods because of their autism. And you find, you know, they've got a very restrictive tongue tie. We do the release, and they have expanded their range of foods because now they've increased what they feel safe eating.
Yeah.
I think this is, I suppose, an important statement as well. You know, if you go out with the aim only to fix the tongue, you are not going to fix the person. Do you know what I mean? And I know we're probably preaching to the choir again here with this kind of one, but the number of people who we see back who are finding body changes, so like say tension in the shoulders, they're moving better, you know, all these kind of things that are there, that, you know, I wouldn't have believed if you'd have said it to me 20 years ago when I first started doing all this, that they could all be connected. But, you know, we're missing the window if we only focus on the tongue.
And we really can't just treat even here upwards. We have to look at the whole body. We have to look at motor planning. We have to look at tension. We have to look at alignment. we have to look at all these things
Mhm.
if we're going to optimize oral function and actually fix the symptoms that the patients are coming with. So I suppose the core, the thing really is education. It's educating professionals out there. The number of parents who come to us who are so frustrated or angry because they have been asking, be it lactation consultants, public health nurses, general practitioners, paediatricians, whoever it is that they are seeing within their community, and they're being given misinformation. Or they're seeing lots of different professionals, like maybe we had a child the other day, they'd been to ENT, they'd been to the dentist, they'd been to the doctor, and no one had actually joined the pieces of the jigsaw together. So the key really is education, but also educating the parents so they can advocate for their child. So we're in the process of launching, or it's just live now, our tongue tie toolbox to try and address some of those needs.
Yeah, indeed. And lots of developments will come. So there'll be several courses in there. Like I say, we have parent guides, and very soon we should have an app that will be working with all this as well.
So any questions?
Might take off that share as well then.
Wow, you guys, that's amazing. I'm so excited for that app. Wow, I can't wait
That'll be
to
really good.
see more of that. That's fantastic. What you guys are doing is incredible, and it is so exciting hearing about all of the innovations and the multiple disciplines and how you guys have come together and really figured that out. The intensive treatment that you guys do is so fascinating. I do have a couple of questions as we were going through. You had mentioned, the frenectomy versus a functional frenuloplasty. And I was hoping that maybe you could explain the key differences between the two and why you prefer the latter for certain cases. I know you kind of mentioned a couple of things in healing and a little less work, but if you could go into that a little more, that would be great. Thank you.
Sure. So I suppose for anyone over 12 weeks, we would use a frenuloplasty. So the difference with the frenuloplasty is that we would, anyone between, if we're doing it who is, say, maybe under 10 to 12 years of age, we would do under sedation. And then I suppose the big difference is we're placing sutures and a bit of periacral glue to bring that diamond. So rather than leaving it open like we would do for the babies that you've got to get in and do stretches, we're bringing those wound edges together. So we're controlling healing. That's not the entire fix in and of itself. They have still got to get that mid-tongue lifting to claim that freedom that we give them, but you haven't got to go poking.
Yeah.
Do you know what I mean? But
and I think the big thing there, I think it's child friendly.
Yeah.
The surgery is child friendly. They no memory of it. They're calm. So their experience is not one that's going to get them defensive around the mouth.
Oh, yeah.
That is huge.
Oh, I know we had one guy come back for his post-op kind of first session of therapy afterwards. So that would have been about 5 to 7 days. And his quote was, it was the best day ever. So his surgery day, having tongue tie release, was his best day ever.
Yeah, because he got to watch videos, he got 3 ice creams, and he got a balloon.
Yeah.
So what more could you want? Because it's got to be a good experience. We can't be doing things that make children scared or worried, because you can't do therapy then. We're not going to get those changes. The number one rule of achieving change is getting that comfort, that openness, and also the actual surgery. When you've got a calm, relaxed patient, you can take your time. Just
but
as
also you can raise that precision. Do you mean like if they're not
100%.
moving and fighting? I mean, I've seen a video online with someone trying to use nitrous on and off and on and off. You know what I mean? And you're getting a 20-second window to do a bit of surgery, and then you're trying to get the nitrous back on. I think it's really hard to work like that. Do you mean it's a challenge? And I think it's, but then if you're also then, because you're squeezed for time to do surgery, or the windows to do that, you're not going to place sutures. But now you're putting on the parents diamond care in a 2-year-old. I mean, whoa, you know, and I get it, you know, everyone's got to work within their parameters of what they can do and, you know, what they're allowed to do within their licensure and all that. But I think pinning down a 2-year-old to do diamond stretches
wrong.
is, yeah,
Yeah.
we can do better, and we should do better.
Yeah, you know, and you know, even within the surgery, they get so much better surgery if you can sort of feel a little bit, we can feel that tension. Conscious sedation, we've still got normal tone. We're getting them moving within surgery, so they're getting the quality of surgery is not comparable.
Yeah. You know, it's going to be hard for someone if they're doing it under general anesthetic, I believe, because they haven't got that tension. So where do you decide that I've done enough?
And you'll probably end up
Sure.
doing that.
Yeah, or you're going one side or the other, but to get that fine tuning, you know, how do you do, you know, tweak this that little bit and go, I can see a tiny strand there, come back in and do. Same as like I work with 6 times magnification for
Wow.
the
Wonderful.
surgery we're doing,
Sure.
you know, so and I need it because we can see, but it's because we've got somebody who will stay still.
Right. And so then, you know, you're making sure you're not losing that tensegrity that you need too from the tongue. So that balance. I love that you guys mentioned that with the conscious sedation too. That's wonderful. I have a question. How do you address concerns from parents who are hesitant about surgical intervention for their child's tongue tie? Which honestly, I wonder with your guys' technique, how many hesitations you have. But when you do, how do you address them?
I suppose what the way before they get to Justin, what I'm saying to them is you can learn to live with a tongue tie. There are so many adults walking around with tongue tie, but you are then using compensations. You are using your body and using movement patterns not in the way it was designed. So yes, you can learn to compensate your speech sounds. You can learn to compensate your movements. You can walk around with your head forwards to open your airway. But all these things are making your life so much more difficult. And they're pushing pathology down the line. So, you know, and the longer we leave it, that's why I think toddlers are such a good age group. They've got all that growth potential. They've got all that just they're wanting, yeah, they want to move, they want to learn. You can't learn if you haven't slept. You can't learn if you're being told you're bold all the time because you won't sit still and you know, or whatever it is.
Yeah, or you can't cope with being told you're not allowed to do that.
And then you then address the concerns about the sedation, etc.
Yeah, you know, and yeah, I get that. You know, it's I suppose, you know, I suppose some of what I would say to them is yes, in an ideal world we wouldn't be doing surgery. Do you mean? But the reality is you've got a restriction that is stopping them from achieving normal function. And, you know, in terms of risk with surgery, I mean, we just don't have them, is the honest answer. Do you mean?
If it's done right.
Yes.
There are people who are doing tongue tie surgeries in people's houses.
Yes.
That is very high risk.
Yeah.
Yeah. So, you know,
that's a good point. Yes, if it's done properly. Thank you for saying that. Yes, but
that's really important.
Well said from both of you. Thank you. You guys mentioned education, which I agree is a huge part of this. What challenges do you face educating healthcare professionals globally about the importance of functional rehabilitation after tongue tie release?
Okay. I mean, I think you've got there. We're still at that point where we haven't achieved critical mass. So as in, you know, so we're in innovators and early adopters phase, isn't it, of where we're at. We haven't got to the point where we're generally accepted. And I think that applies to all the elements of it. So that applies to how we assess, that applies to whether we need to do surgery, and that applies to the care and therapy that goes around the surgery. Do you know what I mean? So I think that there is some understanding or appreciation for the really obvious anterior ties. Do you know what I mean? You know, the screamers that, you know, the person in the supermarket queue can pick out. Do you know what I mean? But they don't get the nuance. And I think once you start digging into the nuance, you realize how complicated the whole field is as well. And 3 people with something that looks identical can have 3 different presentations, one of which might be no problem. and they may actually be normally functioning, and another one who is having awful trouble, and someone in between. So even just purely looking at structure does not answer the whole query either, is it?
Absolutely. And I think sometimes some of the problem is because this is something that affects so many people, if you acknowledge there's a problem, you're actually obliged to provide a service. And that is has huge implications. So I think that's one of the blocks.
Yeah. And also that then goes, well, if this is a problem, but we see so many kids, it's normal to have a lisp, it's normal to snore, it's normal. Do you know what I mean? So it's not, it's common, not normal. Do you know what I mean? But we are, that bit is being taken. Do you know what I mean? And it's transposed.
Yeah.
Yeah.
And a lot of it, you know, people are defensive of where they've been or been working, and it's just being open to learn more. We're all learning. You know, we're doing new things all the time. You know, if we're not open to learning, it's you're not going to make progress.
You know, it's hard to teach somebody who's not ready to learn as well. Do you know what I mean? So, but I think sometimes the thing is where you've got naysayers, but there are the families that we see are going back to their pediatrician or their general practitioners we would have here. Tell them what happened. Do you mean tell them? You know, don't go in gunning for them. You know, we're half the time we're being told, you know, we're trying to protect our patients as well. You know, when they're saying to them, oh, don't do that, it's a fad. It's, you know what I mean? I don't think they're out to pick out or pick off the people who are trying to make a difference, but it's because they don't know better. But then go back and tell them what happened. Tell them what the experience was like, you know, the good and the bad, because the problem is they're likely to see the patients back where it didn't work well because they're still having problems. Whereas if suddenly magically everything's better, you're gaining weight,
you don't need to go to the hospital.
why would you rock back up again? Yeah. You know, so they also see a distorted view of outcomes as well, I think.
Oh, that's so true. And the more we know, the better we do. I love that. I know that we are at our time here. Do you guys have time for one more question?
Absolutely.
Far away. Yeah.
Awesome. I know that you had mentioned steroid injections. What innovations or advancements in tongue tie care do you guys foresee in the next decade, particularly regarding diagnostics or treatment techniques? And do you guys have any experience with serapeptase at all?
Okay, so 10 years is a hell of a long time.
I think you know, the thing we've been talking about is something that measures three-dimensional movements, you know, a non-invasive three-dimensional measurement, because you know we're looking at height or we're looking at elasticity or whatever, but you've got to put it all together.
Yes, I suppose, yeah. When you look at our assessment tools, some of them, they've got functional elements to them, but how do we you know, kind of really bring that together? And I suppose, yeah, we've got a lot of AI stuff now coming. There's you know, we've got a lot of cameras, you know, video cameras and stuff. So will we be able to do, you know, tie something like that together from an assessment perspective? It would be nice to see a validated assessment tool for lip and buccal frenulum assessments as well. I've ideas. I don't know whether anyone agree with where I'm at, but do you know what I mean? So there's things that we need to look at doing. But and then in terms of treatment wise, I mean, I'd like to see the fact that it became the standard of care, you know, preparatory work, and that, you know, therapy work afterwards is seen as the way to go. Whereas we've still, certainly here in Ireland, there's those of us that go that pathway suffer a little bit. Yes, we get better outcomes, but if someone offers you to do everything in one go, in one day and one visit, as opposed to coming back and forth to somewhere, you know, naturally this appears to be the easier, better option. But you know, we're convinced. I resisted switching for at least 2 years, I'd say, you know, because I thought it wouldn't work, as in from a parent, bringing parents here and getting families here. And it does a bit, but we get much better results for it. Do you know what I mean? So definitely. Serapeptase wise, it's something we're looking at. Do you know what I mean? It isn't something that we've used, but there's, you know, yes, kind of watch this space, but it isn't integrated into our practice at the minute.
Sure. I think a lot of people are kind of watching and seeing what people are doing now. There's a lot of neat stuff, I think, on the horizon for us in terms of tongue tie care. And I really love hearing what you guys are doing and that you are at the forefront. We need more people like you guys pushing our field forward and continuing to do that. So that's wonderful to hear. I really want to thank you guys for joining us today and taking the time all the way from Ireland. So thank you guys so much. And the tongue tie box, right? Is that what it is? If you guys want to share one more time so we can make sure to share that with everyone.
Let's see, where are we at?
Just go back there.
Back there,
It's the tongue tie toolbox.
Wonderful.
So our idea with this tongue tie toolbox was that whoever you're working with, everyone needs some sort of toolkit, because even if they don't want to work in tongue tie, their patients are asking them. So we wanted to have something where clinicians could come and take the bit they needed to build their own toolkit that they could help their patients within their own scope of practice. So we're looking at it from a surgical point of view, we're looking at it from therapeutic point of view, we're setting up a joint sort of discussion, multidisciplinary group where people can, like this, just ask questions. But we're trying to look at it from, you know, both aspects in terms of, you know,
therapy and surgery.
Yeah, that sort of structure and function.
And then you guys also have that information and education for parents, which is wonderful. So I think this is such a great resource. Thank you guys so much for sharing this. And I'm excited again, like I said, to see that app when it comes out. And just a couple of just quick things as we wrap up here with Airway Circle. Make sure that you guys, we've got our members joining us today, but always make sure that you guys are getting our newsletter, because that will have our next speakers up in the lineup for next week. Thank you guys again for joining us, and we hope that everyone has a wonderful weekend. Thank you again, Dr. Roche and Kate. You guys have been just fantastic. Have a wonderful, wonderful time, and we look forward to talking to you again soon.
Thank you very much.
Thanks. See you. All the best.